Before we start our session, before I invite the next speaker, I would like to introduce you or to say that we have only 2 speakers instead of 3 because the third one has some health problems. So now we are moving to the next presentation, and I'm inviting Professor Reinhard Busse for his presentation. By me, it sounds that we go off to look to this problem from German point of view. Yes? No. You are from Germany.
Yeah, but I mean, it was not a Dutch point of view.
Okay, thank you.
Yes, thank you. I will do 2 things in addition to what we just heard. We will move, on the one hand, into countries now, not taking country by country, but move into countries. And the second shift is that Johan only briefly touched on healthcare. Of course, screening and so on was already going into that direction, and that I want to have a more specific look into healthcare. So basically, where we just were was something like this. And this is what you all know, what we are presented by the Commission, by WHO. They show us this life expectancy, and then they always point to convergent, divergent, that life expectancy is so different within the European Union. What we often don't see, because also in many countries the data don't exist, is the variation in life expectancy within countries. So by socioeconomic class, whether it's primarily determined by income and or education, will also be depend on the specific country. This is the example of England and Wales here, with a long-standing record of life expectancy by class. And you see here the 6 classes, which they are the 7 classes rather, they have defined, and you see a gap in life expectancy within England and Wales by class when we take the latest figures here by 5.5, 6 years. And if we then translate this to the European scale, we see that the highest life expectancy for males, which is in Sweden, is actually only in the 3rd class in England. So if you are in one of the top 2 socioeconomic classes in England, you actually have on average a higher life expectancy than people in Sweden. And this goes down, so for males in England, the upper one is above Sweden and the lowest one is Portugal. When we do that for women, and we see here again a difference in life expectancy of about 5 years within England and Wales. And then when we transform that to the European scale, we see that English women in the highest socioeconomic group have a life expectancy as in France, which has the highest life expectancy for women, while women in the lowest socioeconomic group only have a life expectancy of that in Poland. So a big part of what we usually think is already the European variation, we see here within a country. Second example, so that was life expectancy. Another thing, what we usually look at if we have data like this here from Scotland, is the degree of people living with chronic illness and especially multimorbidity. And you can see here, this is by age. Usually we think it's always only related by age. I mean, somehow many people think the older we get, the more conditions we have, that as if this were the only and main factor. And you see here that the number of conditions goes up by age. Let's take here in a middle group here, 45 to 49. Then you see, that about 40% have at least one chronic disorder. Some of them have 2, some of them have 3, and that grows by age. When we take the same data and disentangle them, again by socioeconomic status, we get a curve like this here, with the So this is now, before I had from England and Wales 7 socioeconomic groups. This is here in 10. So we have between 1 and 10, and 1 were the people in the best socioeconomic group, 10 in the worst socioeconomic group. And this is a percentage here by age and socioeconomic group, by how many people have are in multimorbidity, meaning having at least 2 chronic conditions. And what factors here is when we go into the same group of the 45 to 49-year-olds, we actually see that the percentage of multimorbid people differs by factor 2 between socioeconomic classes. So when you're in the lowest socioeconomic class, the probability that you have a multimorbid disease, so at least 2 chronic conditions, is twice as high as in the highest socioeconomic group. If you take this longitudinally, you see that the percentage which people in the lowest socioeconomic status reach around age 50, 37% in this example of a GP study in Scotland, that people in the highest socioeconomic group, that there is a more than 10-year gap. So they only reach the same level of multimorbidity more than 10 years later. So huge discrepancies within one country, even a small country like Scotland here. And clearly we could say, okay, we go down, and I come back to that, we go down the health policy route and we try to figure out these differences and, level them out so that we don't have that problem. The other thing is, of course, we could say, okay, we need to look at health care. So health care should then do something about these differences, especially, of course, for these people who are most in need. And unfortunately, I mean, when we look at these here, these are 2 quotes from about 40 years old. Doctors tend to gather where the climate is healthy and where the patients can pay for their services, Ivan Illich. And around the same time here, the availability of good medical care tends to vary inversely with the need for it in the population served, by Julian Tudor Hart. And this was also coined then the inverse care law. And that clearly would be problematic. I mean, people by socioeconomic groups, they also tend to group in certain areas, where we then speak of deprived areas versus the affluent areas. And of course, we would hope that medical care is where the needs are and not where the money is. Now I have some slides on Germany, but also, as you see, I have slides on all kinds of other countries. This is Germany, and on the left-hand side you see the median household income by county. And I've marked certain areas there. The dark blue ones are with the highest median household income. And for example, down here you see the area around Munich. Here is Hamburg, Bremen. This is the Frankfurt area. While some other areas here in light blue tend to be relatively poor. And then on the right-hand side, you see this the physician density in ambulatory care. So this is where physicians tend to be clustering. And you see, when you look at this, where it is dark blue, it's here dark red. And where it is light blue, it's here also light. So in the richer areas, you have more physicians, in spite of all our capacity planning. And in the poorer areas, you have on average fewer physicians. So we have an indicator here that this is true still today. This is a complex figure. I did it yesterday. Yesterday I thought, we are speaking of unmet need here, and I need to come up with a framework actually to explain what it is. And we did in the previous project, we looked at what's called health access. We looked at why people have access to healthcare and why some people do not have access to healthcare. So we said there are basically 7 hurdles on the way to receiving healthcare, and the first one is you are covered for health insurance, can also be a tax finance system. The second one would be then that the services you need are in the benefit basket or are not in the benefit basket, whether you have high cost sharing, even if they are in it, whether the geographical factors means you live in areas where the next hospital, the next physician is very far away. Choice among available providers then means you have to go to one. There might be one hospital, but you have to go to exactly one, and in combination with organizational factors that they have long waiting lists and so on, you don't actually make it. And so after you have passed this whole filter, basically this is then what we can measure as realized access. You have overcome all these hurdles, while the people who fall out are the ones with unmet need. And of course, we have to realize when we talk about healthcare that access is a precondition, but not the explanation. I mean, if you get access to bad quality care, you haven't won anything. So then the important thing is that the first thing is access. Then we need to look at the quality, and access times quality are the outcomes of healthcare. So this is our model here with which we work, and I'm going briefly through the hurdles. The first hurdle, unfortunately, basically in Europe we don't have good data on that, so we have to rely on the US here, people where we have major people or major groups of the population who are uninsured, and of course we are not surprised. These are the latest data from the Commonwealth Fund here, that people have problems in access due to uninsurance, compared to people who are insured. I mean that is no surprise. Then when we look at the benefit basket, which is differing at the edges, also what exactly which drugs are in and not, but this one looks at a more visible area of dental care. And I've marked here in green the countries where dental care is covered, and in red where it's not covered, and yellow is it's not covered in the benefit basket, but most people have complementary insurance for it. And you see here, and then this looks at 2 dimensions: those people who did not go to a dentist in the previous year, in the past 2 years, sorry, this is a dark blue bar, and light blue is people who say, I did not go to the dentist because of costs. And you see, it's not a totally even picture like the Norwegians here, that most people have been to the dentist for probably normal thing, but already quite a number of people say, I didn't go for some treatment because of cost, and Norway is in the red bar. But and conversely, in the UK and France, even though it's covered, you have 1/4 of the population who hasn't been there. But otherwise, you see, it's a clear picture here. If it is covered, more people go, and fewer people have problems in accessing it. Cost sharing, and this is also from the Commonwealth Fund. And of course, cost sharing, the degree of co-payments and so on you are having, has 2 dimensions. The one is the absolute value of the cost sharing, whether you have to pay €2 for a drug or €20. And I put here the UK in yellow because the cost sharing is relatively minor. But if you have a sizable and noticeable degree of cost sharing, which those who want cost sharing actually say you have to notice it, otherwise it wouldn't work. But then do we have protection mechanisms? I mean, we are talking here of differences by socioeconomic groups within countries. So are there protection mechanisms that there's a cap for cost sharing? So after you have paid the first €100 in a year, you don't pay any more. And I've marked here countries in green, which have a cap, and I've marked countries in red, which don't have a cap. And you see again, when we take Canada as the outlier out here, then we see that the countries with a cap, that clearly people have much less of a problem to access healthcare than in countries where there is no cap. And basically you have to pay 20% of every operation, every visit you do. So this was the third hurdle. But we also know that even if we have no cost sharing, and of course often in prevention we say, okay, we don't want cost sharing. We believe, which would be a topic by itself, that cost sharing can steer people to certain certain interventions. Then we say, okay, prevention, we don't want to deter them. We want that they do it. And this was a very nice study here, also from Scotland, by the way. And what they did was they offered colorectal cancer screening here, and they basically offered it to everybody coming to these GP practices. And they looked at who would actually take it up. So it was offered to everybody. And then we saw that people declined it. And the probability that people declined it was adjusted by age, sex, by the actual GP who offered it. So adjusted for all that, the percentage or the odds ratio rather, you see that here, 2.34, the odds ratio, that people in the lowest socioeconomic class were more than twice as likely to refuse the prevention. And let's assume, and of course in this case it works, it is an effective measure. We could say by offering it, we actually widen inequalities. If we would not offer it, people between socioeconomic groups would not diverge further. Because if we see this, then of course a few years later, people in the upper socioeconomic groups are even better off. They are not only in the upper socioeconomic groups, but they were also more likely to have been taking up this screening program. So we are in a problem here. We are actually in a problem. And you already see that healthcare can widen inequities. This is another nice study. Unfortunately, there are very few of these data. This one was looking, and this is from Canada, looking at inequitable waiting times for angiography after acute myocardial infarction. So, and this looked again, this was by socioeconomic status in 5 strata. And so all these patients were having acute myocardial infarction. And basically it was then for the follow-up, would they get another angiography, and how long would they wait for it before they get it, and what was their mortality status after 2 years, I think, at 1 year, after 1 year. And you see it's all standardized here to the highest socioeconomic group. This is all set at 1. And when we're here in the lowest socioeconomic group, starting with the black bar, waiting times to get an angiography was about 50% higher. Oops. To actually get the angiography was about 20% difference, and mortality was also 20% different, but to the other side. I mean, 20% more of them died. This is inversely here. When we look at this, of course, it's not only socioeconomic status. It's not the socioeconomic status per se, but the primary physician also for the lowest economic status was in 30% a GP. For the highest socioeconomic status to care for the acute myocardial infarction, was it only 12%. On the other hand, highest economic status in 42% a cardiologist, lowest socioeconomic status only 24% a cardiologist. 89% of the better off people were treated in a high volume hospital with the expertise for acute myocardial infarction, only 67% of the lower socioeconomic status. the next tertiary care hospital was more than 50 kilometers away for only 10% in the highest socioeconomic group, but for 53% in the lowest socioeconomic group. So again, also in Canada, we see that care is where the richer people are. And where, if they are there, where the care is, they get better care and better outcomes. These data, some of you might also know, OECD is publishing them on a regular level, and this looks at the realized access. So we now say, okay, we don't know where people get lost on the way and why, depending on their need, some people make it to see their GP or make it to see their specialist. We can only say, in regard to their need, what we can see here is, and let's look at maybe the most visible are these blue dots first on the upper corner here. So these ones here, they are all very high up, which means there's pro-rich inequity. All things equal, your medical condition equal, age equal, sex equal, and so on. The probability that if you're in the highest socioeconomic group that you see a specialist are much higher than if you are in the low socioeconomic group. While for GPs, these are the green dots here, we see some countries actually where there is pro-poor inequity, while in other ones there's also pro-rich inequity. And there are certain countries, and you see here Greece is a good example. Basically, you can say, if you're poor, you see a GP, and if you're rich, you see a specialist. And this is the opposite then. So you remember maybe the framework, we had the realized access if you make it through the filter, and the unmet need are those who fell out. And we have talked yesterday about unmet need figures country by country. So we only looked at country averages, and you remember there was some debate whether it has gone up during the financial crisis or not. This is now not looking longitudinally. Let's focus only on the left side. Right side is dental care. And this looks at the same. Yesterday we only saw these middle figures here, these average figures by country. This one takes the same data and says, okay, let's look at within country variation. And we see here your neighbor Latvia has not only the highest value, but also the highest inequity. So if you are in the high income group, you only have an unmet need of about 13%. And if you're in the lowest socioeconomic group, you have an unmet need of about 34%. And you can take this clearly, and on the other hand, that means, and if you're rich in Latvia, you're doing better than people in Bulgaria, Poland, Romania on average, and you're doing as well as a poor in Sweden. So rich in Latvia is as good as being poor in Sweden. So really, country averages hide these big differences within countries. And that we know from other studies here. This is the averages across European countries. By gender, very little difference. By age group, yes, I mean, young ones usually don't have high needs, so the unmet need is also low. And you see here the steep increase by income measured in 5 quintiles, and not as steep increases here in employment status and educational level. So income really is the best proxy to look when we want to look at these inequities. So what can we do? Well, the first thing is we could say we tackle the inequalities at root. We make taxes higher and redistribute more money so that everybody has the same money, and we wouldn't have the problem of inequitable income. Good idea, but actually the evidence which we have says that the strength of the association between health and income is stronger than when you look at the unequal distribution. So probably, I mean, my conclusion from that is Evidence-based would be we say, okay, we start with health policy. We start within the healthcare system. A certain degree of redistribution is of course necessary, but it's really, first of all, and also a problem for health policy to tackle these things. How do we do that? So if we have a focus on health policy, we could say, okay, we have these disadvantaged. We know the people in the low socioeconomic groups are worse off. So let's do special targeted programs. We know if we offer screening to everybody, it doesn't really work so well. We have seen problems. Some countries, like in England, they call that health action zones. They have said, okay, we tailor to the disadvantaged. Unfortunately, the results are also really mediocre. I mean, I'm not saying you shouldn't try it. Maybe somebody is coming up with really the good models, but it's not really what you say, okay, this is really evidence-based, take it off the shelf and implement it in your country. So my best solution, I'll show you a few more slides here, is take inequities explicitly into account when designing the overall health system. So we know we have a problem with screening, probably not only in Scotland. We have a problem with angiography access, not only in Canada, but we would see all this in our own countries if we dare to look and if somebody really takes the data. And so then we need to start with the money, financial allocation. And this looks the same here again in Germany, the third picture. So we have already seen that doctors are where the money is. Then we have this financial allocation mechanism, which gives more money to areas in higher need. So actually now the money goes virtually first to areas with higher need. So they could go to physicians, to hospitals more often. And then what we did here on the right-hand scale is then that we took the so-called equity index, will be, or is just published in health policy here, and then we look basically in regard to the money which we allocate to people in a certain area, do they go more often or less often? Red means they go more often, which doesn't wonder us. I mean, the people around Munich, they are healthy, but have many physicians and still go to physicians, so they consume many more healthcare than they should consume based on German average by need and need adjusted, while the people in the East, few physicians, high need, they have a blue in the blue areas here, they have a lower than expected or lower than needed utilization, you could say. So we give the money to them, or to their sickness funds to spend on them, but it's not spent where it should be spent. So financial equalization is important, and there are other countries where you can see that from the disadvantaged and the advantaged areas. These are older data here from England, when they still had 183 health districts. And we see here in Manchester, on average per capita, Manchester would get 1/3 more money than the average, while West Surrey got 18% less money. And you can still see, I mean, that this correlates also quite well to the average, to the mortality vis-a-vis the English average. But money itself is not enough, as we see. There's a really nice website from England, I wish more countries had that, which now compares the by now 150 local authorities by health. And if you're in Manchester and you go to this website, you see you are really in deep shit. I mean, you have the highest death rate in the country, and you see it's 455 compared to Wokingham, 200 within England. More than factor 2 different. You see cancer, you're at place 150 out of 150. Again, almost twice the cancer deaths compared to the lowest health local authority. Heart disease and stroke, factor 3. While when you see, and now I go back to Surrey is in the, says here, socioeconomic decile number 10. Manchester was number 1. And you see, okay, you're reasonably well off in Surrey. life is nice, you know, you have much better health outcomes and so on. So redistributing money or more money to areas in social deprivation, which also have much worse health, in itself is not enough. And we know that, I'm skipping over this here. No, by the way, I need to go back. This is again from Australia. And we are now at the outcome side. So we say, okay, people probably die more often of cancer because they don't get good health care and so on. This looks specifically at causes of disease, which we call amenable mortality. So these are only the causes of disease where we know that good health care should decrease or even eliminate these causes of death. This is again by socioeconomic status here. And we see also the results from healthcare, this time from Australia. They differ. If you are poor, you die more often from causes where you shouldn't die if we had a good healthcare system, and vice versa. But there's also good news. And this is from the US, surprisingly, from the US. I returned to the US here. And what we see here is mortality amenable to healthcare. So the same conditions. Let's take diabetes. We don't think that you should die of diabetes before age 75. Conditions like that would be in here. That in the US, when we take race as a criterion for inequity, we see the national average is 96. So 96 per 100,000 die of amenable conditions. When you're white, it's only 86. When you're black, it's 183, so twice as high. When you then look at the two red boxes here, we see that in states which are doing better on average, they have a much better health system. It's not only lower, the mortality rate is lower, so fewer people die, but also the inequity between white and black is very small, while in the bad states with a bad health system, it's not only bad for everybody has a higher mortality rate, but the inequity is especially high. So a good healthcare system reduces inequities. A bad healthcare system has big inequities. And I have one last example here, and this was the quality and outcomes framework in England. And physicians were paid a bonus depending on certain process measures, how many people they screen, how many people they measure the blood pressure and so on, but also on outcomes, how many people with high blood pressure would reach a normal blood pressure and so on. These are the results over 3 years here. This is year 1 when this whole thing started, and the 5 colored bars here are GP practices in rich areas and poor areas. So again, in these 5 quintiles, good area, medium good area, medium bad area. What we see here, the quality score is on the one hand is in bad areas is lower. The GPs reach worse results, and we have a higher variation here. Then over time, we pay physicians a bonus to reach good results. What can you see? You can see that it goes up, but this is not what we're talking about here. But the worst ones move up most, and the variation gets smaller. So the idea here is you pay everybody for good results, but you receive the most progress in the areas where with the poorest areas, because they also had the biggest problems. And then if you motivate, incentivize the physicians to become better, this is where the results are. And so this is the take-home message. I think you saw originally I was asked a question here. And we see healthcare can worsen inequities, but it can, if we are wise, can also improve them. And inequity, in my conclusion here should be taken as a center of health policy, just as inefficiency and bad quality. It's not something for some outside, some well-meaning people who are about equity, while all the mainstream health politicians talk about efficiency and quality. Rather, it has to come together, because if we leave if we leave it to the well-intended people to help the disadvantaged, this also has unwanted side effects. We saw that with the Glasgow example of the screening. So this is nothing where we said, okay, we do something for the disadvantaged here. It has to be in the center of health policy. I think the only viable solution is better healthcare for everybody, and we need clear incentives to improve access. Whether you call it pay for performance or you do it differently in your country is up to you. We need to look at all these 7 hurdles: financial protection, geographical inequities, and so on, and look to quality, which comes then, access times quality, and only then we see good results. For monitoring success, I think it's crucial that we get data much more in time than we now do. We would like to see these unmet need data, I would say every half year. Okay, maybe once a year, but then really on time. And we need health services researchers looking into these things really much more, because I had a hard time working on this. It took me a long time to find these examples. There are simply not enough examples. There are not enough people studying this. Thank you.